So welcome to the hybrid suite of Clinic Pasteur for this TAVI case with the Accurate Neo 2 device. It's, as you've seen, a regular transfemoral anatomy. Ole, should we start with describing the setup of the patient?
Yes, so setup is, we kept it pretty simple. We have two 6 French radial accesses. The left one is for the pigtail. The right one is for the sentinel cerebral embolic protection, which we just placed. And then we have one pre-closure ProGlide and a 14 French eye sleeve, which we already introduced just right now, the AL1 catheter. Okay.
So now if you focus on the fluoro, you can see the sentinel in place. And we had to use a trick. What was it, Ole, to deploy the sentinel?
Indeed, that's true. For the sentinel placement, he has a pretty short sending aorta there in a way and a bit curved. So we had to let him take a deep breath, under inspiration. Otherwise, we ended always up in the descending aorta. In that way, inspiration, we ended nicely in the ascending aorta, and then we could place the sentinel in the regular way. Yeah.
So if we continue with the angio, focusing on the screen just in front of you, now we have the two cusp projection. That was a RAO 15 caudal 15 projection, and we can nicely see the stent, the distribution of the coronary arteries, and quite decent overlap of the left and the right coronary cusp. And here is the free cusp planar view. That is more a LAO 8, a cranial 8 projection with a nice distribution of all three leaflets. So the ACT is above 250. We are happy. So let's start the case.
Yeah, then let's cross the valve. That's the first thing to do.
All right. Which wire do you use, Ole?
This is a regular straight tipped wire. Yes. So that's we're going to do that. I personally have a small preference for going in a crossing in a cusp overlap almost. That's like I use that a lot because then you know exactly the anatomy. You know that the pigtail is in the non, and then you know the other two are overlapping on the other side. So you know exactly how the anatomy looks like. Yeah.
So I'm bringing you to the cusp overlap projection, and just in case it's a little bit more difficult because sometimes you have very calcific leaflets, do you use that combination of M-plates left 1 and a regular Teflon coated wire, or do you use something else?
Yeah, then sometimes I go to a Terumo wire or something like that, yes. So then I change definitely to a more fluffy wire, I would say.
Okay.
Yeah. But now I like to exchange into the LV with an exchange wire and to a pigtail.
So let's use the exchange wire now.
Yep. Okay, so now it's nicely in. Sorry, I'm gonna be in the fluoro here. Yeah. So AL1 is nicely through. Maybe you can take over here.
Yeah.
Yep.
And then Pauline, we're gonna use the pigtail.
Yeah. And then as we are going to use the Accurate Neo 2, of course, it's very important, I would say, that we place that guide wire, stiff guide wire in the ventricle, which is going to be a Safari small.
Yeah.
That we place it very correct, yes, that the curve is facing upwards. It shouldn't be inverted. That's really critical, I would say, if you do Accurate Neo 2.
So and it's really a key point for that device, huh?
Yeah, I think so. Yeah, it's definitely needed to do it that way. And you like to keep it rather apical. I mean, at least you don't want to have it just sitting mid cavity, LV cavity. You want to have it deep enough in, because that's important when you do the final release of the valve, that it actually, the stent holder can travel nicely into the LVOT up to the mid cavity portion. Yes.
So let's record the pressure of the patient.
Yep, I can connect here.
Yeah.
All right, that's fine.
Okay, nice. So if we now if you focus on the upper right panel, the hemodynamic tracing, so what we can see, maybe we can flush a little bit more the ventricular pressure. So we see that there is a right bundle branch block. That could be an issue. Let's see how the patient reacts. There is a peak-to-peak gradient that is above 40 to 45. The diastolic aortic pressure is 57, and the left ventricular and diastolic pressure is close to 20. So the heart rate is 65. So these are the metrics that we have to keep in mind to analyze everything at the end. Safari small. So that's your wire of choice for any kind of accurate cases, or?
Yeah, well, I would say only in these particularly ladies with very small cavities, like very thick hypertrophic ventricles with a very small LV cavity. Then I maybe will opt for the extra small, but otherwise standard, mostly the small Safari.
Excellent.
Okay, so we're going to introduce that into the LV. And our pigtail is already nicely positioned in the non-coronary cusp, as you can see on the fluoro. Yep. So let's try to position this really nicely, I would say. Let's see if this is, maybe we can still optimize it a bit more. Let's see. Yeah, this should be okay. This should be good enough. Yeah. All right.
Okay. So let me keep it everything in place. And as you said, everything towards the outer curvature of the aorta.
Yeah. Exactly. So this is good. Curve facing upwards, not just missed cavity, more apical wise, and correctly what you said, outer curvature of the ascending aorta. So we're good there. Of course, now we go with the balloon. We have to pre-dilate. I would say it's almost mandatory if you do accurate neo2. Definitely, if it's good calcified, to have a really nice, proper expansion of the valve when you do the final release. So in 95 to almost, I would say 100% of cases, I go for a pre-dil. And
so here it's going to be a 20 millimeter balloon.
Yes, 20 millimeter balloon. It's somewhere between the minimum diameter of the annulus and the perimeter derived mean minus 1 millimeter. In between that range, it was here in between 19 or 20. So okay, we go for a 20 balloon. Yeah.
Nice. Okay, Ole. So let's move with the 20 millimeter balloon for that BAV.
Indeed. Let's bring it up. And of course, this is a patient with a right bundle branch block, so we have to be attentive for what we do with the balloon and also for what the rhythm does. I think I will position this balloon not too deep into the LVOT in order to try to avoid really impingement on that conduction system.
Okay.
You cannot always do that.
So let's set the pacing system now, Ole.
Yes, so one electrode here just to the skin, close to the sheet. And then the other one here connected to the stiff guide wire. All right, I think we're set here.
And we can do it with a needle as well.
Yeah.
Through the skin.
Yeah.
Okay.
Okay, so let's see where we are. Indeed, it looks okay here. I'm not going to go much deeper here.
Deeper than that?
No, not really.
Okay.
Good.
So pacing on 180. So the pacing is accurate, as you can see in the ECG.
Very good.
So let me inflate.
And keep a little bit forward push on it.
So full inflation.
Should be good. And
deflation.
Deflation.
And pacing off. And we're going to keep the heart rate close to 40. Just to see if the patient recovers, because as you said, Ole, there is that right bundle branch block, but it seems to be okay.
Seems if you look to the ECG, it looks good. Then we can disconnect here. Okay. Yeah, and we can pull back. We keep the wire in position.
So thank you, Axel. Okay, supposing I'm going to give you the balloon, and we're going to keep the wire in place, and we'll be ready for the valve now.
Yeah. Okay, so now indeed ready for the introduction of the valve. So I think we are going to aim for commissural alignment. So there's some tips and tricks here to do that. Let's get the valve first over, and then we comment on that.
So the device is there, the accurate Neo 2 23 millimeter device is here. So what do we have if we start from here, Ole?
Yes, so the valve is in here in the capsule. We have this small loader that's going to be only partially introduced in the eye sleeve. We're going to go forward the valve for couple of centimeters, and then we're going to take this loader back to the handle. And then you have the handle, we can comment on that later, there are two knobs on it. But now for the introduction, it's important that we keep the flush port kind of 6 o'clock. Then we kind of make our life easier to get commissural alignment later on. It's not patient-specific commissural alignment, but it reduces your amount of torque you have to do. That's we know from some studies. So okay, we're ready for introduction. So as you see here on my hand, I put the loader a little bit in, just 2 centimeters in. Now I push the device a couple of 20 centimeters forward, like this, and now it's already enough to get this back to the handle. Okay.
And I'm going to connect it here to the handle. So we are at 6 o'clock. Let's see how the device reacts in terms of commissural alignment.
So now we go through the expandable eye sleeve, 14 French. It goes smooth. Typically, it's very smooth. We will show that on the fluoro. It's very nice to cross this aortic arch. It's a very flexible system. As you can see, it very nicely bends. And then
no real interaction with the sentinel, which is good.
No, exactly. And then now we already bring it a little bit closer to the aortic valve. We can maybe MAC 1 in. Then we can see better on the posts what we see. So indeed. So now this is the first step for our commissural alignment manipulation. So you see these posts. So first of all, what you see, the first black part is the stent holder on the bottom. Then you see the square marker, fluoroscopic marker. That's we're gonna put it at the level of the annulus or just above the annulus. But then above that, you see these posts, and we have a 2-1 configuration. So 2 posts are on the left-hand side. One is already isolated on the right-hand side of the fluoroscopy. So that means we're going to go for a clockwise maneuver when we do the commissural alignment.
So maybe we can record that for you. It's going to be more easier to observe with a cine run.
Okay. So here you see now the posts on the left-hand side are overlapping. We have a 2-1 configuration. So we're going to go a clockwise turn. Now we're going to go for the cusp overlap, where we're going to do the actual turn of the handle. Yeah. I can move the table a tiny bit lower indeed.
So let me reach the cusp overlap projection, but it seems already good.
Yeah, this is good. Yeah.
Okay.
So now we're going to make the turn on the first part of the handle here, so we don't touch any of these knobs, that we don't deploy the valve by accidident. So now we're going to make a clockwise turn.
Rotation. And the focus is only on the post that it's facing up front towards the commissure between the left and the right.
Yeah, we can look at the post, and then we can also look at these 2 small wings. Now one of the wings is disappearing. That's a good sign. That free cell there, we call it. So we're almost there. This is perfect. This is perfect. Yeah, I think we're there. Then now we can kind of release our hands while it spins back, and we can check if it's still there, and it's still there. You see that? That's good. Now we go back to the tricuspid then, and then we do our regular implant for the height.
You always start in the cusp overlap projection, and then you move to the free cusp for the deployment.
Yeah, that's the official instruction to do the implant. So now let's focus really a lot on the depth. We have to be really sure that our pigtail is nicely in the bottom.
So let's now do a root shot, very short one.
Yeah, okay, let's do that. Yeah, I think it's nicely there. So now what we do is, first of all, we're going to bring that marker nicely to the level of the annulus, somewhere there. It looks good. Yeah. And at the same time, I think the upper crown, these 2 small hands in the catheter, as you can see, they are still above the calcium. Yeah, I think this is a very good starting point. You see the marker is at the annulus, just at above the annulus, virtual annulus level, and our upper crown is still above all the calcifications, because it's important that the upper crown opens up above the calcified leaflets. So I think we're in a good position here to open up.
So let me just, if you just focus on the handle now. So now it's a very ergonomic handle. We have those 2 parts. The first part is going to expand the upper crown, and the second part, after the removal of that safety knob, is going to expand the lower crown and then the stabilization arches. So let me go very slowly. For the first part, it's a counterclockwise rotation, and very slowly. This way it's going to be maybe easier for you, Ole, to adjust. Are you happy now?
Yeah, I'm happy. So now you open, you see the upper crown opens as a first, which just will, now you go further counterclock, of course, and then we open up the stabilizing arches on top. I keep my right hand on my catheter, and I keep a little bit of forward push already. I went like 2-3 millimeters deeper in already. Yeah. So now you go full stop with this handle. Full stop. Okay, then we can already take the pin out, the release pin here at the back. Yeah, that's good.
I just have to press on top, on the top part of the button, and put it there.
So now I think we're at
maybe a root shot.
Yes, we're gonna make
it's going to be easier for you to understand.
I agree.
Where we are.
Okay. So what can we see here? I think we can still push ourselves 2 millimeters lower. Exactly. That's if you look at the marker. Next thing I look at is the bulging of the wire. So this is, I would call it just a mild bulging. We can definitely go a little bit more push, so it bulges a little bit more. So what I'm going to do now, I'm going to introduce the device a couple of 3-4 millimeters lower. Yeah. Yeah, like this. We make a new root injection. Yeah. Yeah. Okay.
And let me generate the bulge now.
Yeah.
Just a bit, just a small push on the wire. And here we are.
Yeah. Okay, so I think we have a nice bulge. We do a final check, I think, here. I think, yeah. And then if we're happy, you make a very quick deployment.
Yeah.
I think we're good
It
there.
looks good. It looks
Yeah.
good.
All right, then we're ready for it.
Yeah.
Yeah,
You
go ahead. Yeah, go, 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 go. Yes, perfect. Very nice.
And it's good to see that downward movement of
Exactly.
the nose cone.
So we can see it on the fluoro again. You will see it diving down. Yes. So we have detachment of the stent holder and the stent. That means we had a good push on our valve, which is good. Also visually, what we can already see is that the upper crown is kept nicely above the calcified leaflets. So we have a good position here. And it looks even nicely expanded in this projection.
So very important for this particular patient, Ole, and for you, the right bundle branch block is very stable, no heavy conduction disturbance at all, and that's one of the beauty of the device.
Yeah, we also didn't pace during deployment. Exactly, yes, so now it's very important that we go full stop. Yes, that's good.
So here we are.
All right, so we pull back on the wire a bit.
Yeah, just to make sure that we are disconnected, and we watch carefully the stent holder.
Yeah, that's very good. Yeah.
And then we'll just a nose cone now, and I'm gonna reinsert.
Yeah, that's good. Now the wire can come forward. Yeah. So now we retract the device until here. Yeah, here we stop.
And we're gonna invert everything.
Yeah, invert number 2, and then also number 1. Sometimes the wire tends to come a little bit back, but that's good. Yeah, perfect. That's it.
Okay.
All right.
So let's remove that and then reassess everything.
I agree. Yep.
So okay, Ole, maybe we can remove the pigtail, and because it's still jailed between the sinus wall and the accurate Neo2 stent frame.
Correct. We kept it there.
You always use a wire to do that. You don't pull on the pigtail.
Yeah, absolutely. And especially in this valve, I would say it has these open architecture of the stabilizing arches. So if you pull it, you could theoretically pull on the stabilizing arch. So what we do is we use indeed the wire to push ourselves there out, and then stretch out the pigtail, and then I slowly pull this back. I'll put it already a bit lower again. Yeah, like this is perfect. Yep.
And then
a little bit reconnected to the contrast. Yeah. All right, that's perfect.
Perfect.
Yep.
Okay.
Okay. Good. So then we're ready to make a check here. I think it's good here because the leaflet, the beauty of this valve, of course, is that the leaflets are supraannular position. So you see these posts. Now I think this is the proper position of your pigtail. It's between the top of the stabilizing arches and between the posts to make your contrast injection. Yes.
Yeah, as you see, the commissural alignment, as Ole has mentioned, is perfect.
Yeah, I think so too. I mean, we have almost commissural alignment to only a mild. You see, what we want is 2 overlapping posts on the left-hand side, and the commissure between the right and the left cusp is pointing to the right, and that's where we have an isolated post of the accurate. So I think we have commissural alignment to maximally mild commissural misalignment. Yes.
Okay.
All right. Good. So we're almost ready here for the injection. Go for a cine.
Okay. So Pauline is ready for the angio, so let's record that.
Yeah, okay, let's go for the angio. Yeah, that's really nice. Perfect. Yeah. So what you, again, so commissural alignment, what you can also nicely appreciate, especially when you give the contrast there, you see that the calcium there, you see the white sparing in the contrast, that's where the upper crown is just leaning on top of. So that's actually really good. So the position of the valve is excellent. So then it's now a discussion whether you should post-dilate, yes or no. I think
so. Maybe we can connect that with the hemodynamic. So if we focus on the hemodynamic of the patient, so the heart rate is exactly the same as it was at the start. It was 16.6, it's 69. No gradient, but that's what we can expect from a supraannular device. The right bundle branch block is really stable. We see a nice diacritic notch of the aortic wave. And there is a huge discrepancy between the diastolic aortic pressure that is 60 and the left ventricular end diastolic pressure that remains around 20. So I guess from the hemodynamic standpoint, it's okay.
I agree.
Personally, I don't think we should do anything else.
No. I mean, we have something to lose here too. As you say, right bundle branch block. If we go for post-dil, we will increase the risk of an AV block dramatically. So I think I would also accept this. This is a trace leak we have. So I think we should accept this. Yeah.
You happy, Pauline? Yes. Okay. So maybe it's time now to remove the pigtail and to remove as well the Sentinel device. So I hope you did enjoy the case. That was a really step-by-step description of a contemporary transfemoral TAVI case with the accurate Neo 2 device. So Ole, you did a master a piece job achieving such a case in a very standardized way, and I hope that you learned a lot from Ole and myself. And so you can see how we all work as a team with Pauline and Axel. So thank you, ladies, for that. And we wish you a very good London Valve.
Thank you. Bye-bye.